Welcome to The Explainer. Today, we're diving deep into one of the most dramatic and time-sensitive crises in all of medicine, the ruptured abdominal aortic aneurysm. We're talking about a catastrophic failure of the body's largest blood vessel, a condition where the clock starts ticking the moment it happens, and every single decision can literally be the difference between life and death. All right, so to really get a handle on this emergency, we're going to follow the complete clinical story. We'll kick things off at the moment of rupture, then we'll rewind a bit to understand the science of why the aorta fails in the first place. From there, we'll join the ER team as they race against the clock to diagnose it, weigh the life or death surgical options, and finally, we'll look at the tough road to recovery for those who make it through. So our story begins where it so often does, right in the middle of the chaos of an emergency room, with a patient showing up in a state of sudden, severe distress. Okay, a ruptured AAA should be on your radar for any patient who shows up with this classic triad of symptoms: sudden, tearing abdominal or back pain, signs of shock, like low blood pressure and a racing heart, and a pulsating mass you can actually feel in their belly. But here's the catch, and it's a big one. Only about a quarter to half of patients will actually have all three. So what is physically happening inside the body? Well, the aorta, our main artery, has developed this weak, bulging spot. That's the aneurysm. Think of a weak spot on an old tire. A rupture is when that spot finally gives way and tears open. And let me be clear, this isn't some small leak. It's a catastrophic structural failure happening under the full force of the body's blood pressure. Now, this slide is absolutely fascinating because it explains why two patients with the exact same condition can look completely different. A contained rupture means the bleeding is kind of temporarily walled off by other organs. That patient might be in absolute agony, but their vital signs could be stable for a little while. On the other hand, a free wall rupture is a total blowout. Blood is just pouring into the abdomen, leading to massive hemorrhage and profound, often fatal shock. So the rupture itself is the crisis. But to really get it, we have to look deeper into the science. Why does this incredibly strong aortic wall fail in the first place? At its very core, this is a biological process of decay. The very materials that make the aorta strong and stretchy, the elastin and collagen, are systematically broken down. The wall just gets thinner and weaker, and it starts to stretch under the constant pressure of blood flow, kind of like an overinflated balloon that's about to pop. And this perfectly illustrates the single biggest predictor of a rupture: its size. Just look at how that risk climbs. Below 4 centimeters, it's pretty much zero. But once you cross that 5-centimeter mark, the risk just skyrockets exponentially. That's why 5.5 centimeters is often that critical line in the sand where surgeons say, okay, let's fix this electively before it has a chance to rupture. But, size isn't the whole story. A bunch of other factors can hit the gas on this dangerous process. Being female carries a nearly 4 times higher risk for any given aneurysm size. If you're a current smoker, that doubles it. And high blood pressure, age, and family history, they all play a part in weakening that aortic wall and pushing it closer and closer to the breaking point. So now that we understand the why, let's get back to the how. How is this diagnosis confirmed when every single second is absolutely critical? When that patient hits the door, the whole team has to move, and they have to move fast. There is no time to waste. You need a rapid, life-saving protocol to get from just a suspicion to a definitive plan of attack. The Society for Vascular Surgery gives us this life-saving algorithm. First things first, stabilize the ABCs, airway, breathing, circulation. Second, realize this can often be a clinical diagnosis. You don't always have to wait for a scan. But then look at number 4, permissive hypotension. This part is so important and a little counterintuitive. It means you intentionally keep the blood pressure low. Why would you do that? Because if you aggressively pump in fluids, you can raise the pressure and literally blow off the fragile little clot that might be holding back a full-on hemorrhage. You're just trying to keep everything calm until the surgeon can get control. Now, for any patient who is stable enough to make it to the scanner, a CT angiogram, or CTA, is the absolute gold standard. It's incredibly accurate. The telltale sign is seeing that contrast dye actively leaking out of the aorta. But just as important, the CTA gives you a detailed anatomical roadmap, and that is absolutely essential for planning the repair, especially for figuring out if the less invasive option, called EVAR, is even on the table. So the diagnosis is confirmed. The surgical team now faces a massive decision. The choice they make right here can have a profound impact on whether the patient lives or dies. And the two main options are really at opposite ends of the surgical spectrum. You have open repair, which is the traditional all-out approach, a huge incision, physically clamping the aorta, and sewing in a new graft. Then you have EVAR, or endovascular aneurysm repair. This is the minimally invasive revolution. Surgeons use wires and catheters to basically snake a stent graft up through arteries in the groin and deploy it inside the aorta, sealing the leak from within. Because it puts less stress on the body, guidelines strongly recommend EVAR if the patient's anatomy is suitable. But, and this is a really big but, this is where things get tricky. When we look at the highest levels of medical evidence comparing these two emergency procedures, we run into a real dilemma. Let's start with what we consider the gold standard of medical proof: randomized controlled trials, or RCTs. These are the best because they get rid of bias by randomly assigning one treatment or the other. And when you look at all the major RCTs and their reviews, well, as you can see, the conclusion is pretty consistent. There's no significant difference in short-term survival between open surgery and EVAR. Okay, but then you look at a different type of evidence, these huge observational studies that analyze real-world data from tens of thousands of actual cases. And here, a completely different story emerges, and it's a compelling one. Multiple large studies consistently find that EVAR is associated with lower mortality. This conflict between the pure evidence from trials and the messy but massive evidence from the real world is one of the biggest debates in vascular surgery today. For the patients who managed to survive the initial rupture and the emergency repair, believe me, the battle is far from over. The postoperative period is an absolute minefield of potential challenges and complications. And before we even get into those complications, let's start with the most sobering number of all: 81%. That's the estimated overall mortality rate for a ruptured AAA when you include everybody, even the people who die before they can ever make it to a hospital. It is a truly devastating figure. Surviving the operation is just the first giant hurdle. In the ICU, the body is just reeling. The massive blood loss and all the fluids they get can cause dangerous swelling and pressure in the abdomen, a condition called compartment syndrome. The shock and temporary clamping can starve the colon and the legs of blood flow. And the kidneys? They often take a massive hit from the initial low blood pressure and the contrast dye used for the CT scan. So, to kind of bring this entire journey together, it all starts with a weakened aorta that finally ruptures, which leads to that classic clinical picture. An urgent diagnosis is made, followed by really careful fluid management and that critical decision between open and endovascular repair, all while knowing that the overall prognosis is incredibly guarded. And this all leaves us with a critical question, not just for surgeons, but for all of modern medicine. How do we balance the gold standard evidence from these perfect trials with the compelling but different evidence we see in the real world? How do we put all of this information together to give patients the absolute best chance of survival in their most desperate moment? It's a challenge that physicians grapple with every single day. Thanks for joining us on The Explainer.